Hello, everyone from all over the world. Good morning from Brazil. It's 10:30 in the morning here in São Paulo. We have a lovely day today. And I would like to say good afternoon to Professor Falk Schwendicke. He's in Berlin, Germany. And I would like to introduce you to all of you. First of all, I'd like once again to thank all of you. We have more than 2,000 participants from all over the world attending this meeting, and this is a great opportunity for us. Thank you so much. As you know, Professor Falk Schwendicke is a well-known international speaker. He has been giving lectures for many important meetings all over the world. In fact, I attended one of his lectures last Saturday because he gave a lecture to Brazilian IADR division last Saturday, and he has been doing this into many different countries, and we have had a great opportunity to attend his lectures in many different ways. His CV, Professor Falk Schwendicke's CV, has many relevant informations regarding his academic and professional history. And we have to select a few information to share with you today. So Professor Falk Schwendicke is the head of the Department of Oral Diagnostics, Digital Health and Health Services Research at the University Hospital, the Charity in Berlin, Germany. He also is the founding director of the Berlin Institute of All and Health Policy, and he is a visiting fellow at the University of Otago in New Zealand. Professor Schwendicke currently serves as associate editor of the Journal of Dental Research, president of the German Association for All in Dentistry. He is a topic driver dental at the ITU-WHO group, All in Health, and he is also vice president of the German Society of Oral Epidemiology and Health Services Research. Professor Schwendicke holds a PhD from the University Hospital, the Charity in Berlin, where he works nowadays. He has his Masters of Dental Public Health from the University of Manchester, and he received several awards, and among them, I would like to nominate the IADR Emerging Leader Award, IADR Basil Baby Young Investigation Award, IADR Lion Dental Research Award for Junior Investigators, and the David Sackett Award for Evidence-Based Medicine. So as you could notice, there is no doubt we are in front of a brilliant researcher and lecturer. And before I give Professor Falk Schwendicke the word to start his lecture, I'd like to thank very much DMG Company, especially Dr. Suzanne Effenberg and Dr. Angela Shimaoka from Brazil. And I would like to remind all of you who are attending this lecture that you can make your questions using the question and answer box here at the Zoom application. Thank once again for all of you, and welcome Professor Falk Schwendicke.
Yeah, thank you. Thanks for that very kind introduction. And thanks for the attendance to be here. I heard there quite a lot. It's a well-attended meeting, which is fantastic. And it's obviously the way we do this stuff at the moment. So I hope you enjoy it from different time zones. As you can see here in the background, of course, it's not the true background, but as you can imagine, the weather is quite nice here too. And indeed, it's a sunny day here in Berlin, a sunny later afternoon. So I hope I will be helpful for the next hour to you. And I hope to introduce some topics you haven't heard at that meeting, which has obviously a wide range of aspects there. So you should see my presentation here now. The title is a bit provocative, you could say, and it's basically emanating from a lot of discussions we had over the last years concerning the technologies of sealing and infiltration, and comparing them with the more traditional approaches of remineralization and also other non-invasive techniques. And I termed my talk The Good and the Evil, or the first and the second line in early caries management. And of course, as you would imagine, that it's probably not the good and the evil. I can take that away already at the beginning of the talk, but rather the first and second line in early caries management. And I will try to explain this to you, why I think that and what kind of aspects are especially relevant from my perspective. I will go over this a bit quicker because I was told I have 60 minutes. We now had already some minutes for the introduction, and I hope to have a discussions with you at the end for maybe 10-15 minutes. So I will not linger too long into explaining what carious is and that kind of stuff, because you've heard that also in other parts of this conference before. What is probably important to mention and to emphasize once more is that we imbalance in the biofilm, but also in the and demineralization processes associated with dental caries, because that gives us the opportunity to, at the end, control the caries lesion as well. I hope you can see me because my internet connection says it's weak, but yeah, it says you were cut off for a few seconds. Can you hear me now again? I think it should be fine again. So I will just leave the chat open here on the side to see if I'm cut off again. So what I just mentioned before I was cut off is that we are not so much focusing on the infectious nature of caries any longer, which came with the notion to eradicate all biofilm and bacteria, but rather on the ecological imbalance in the biofilm and the de and remineralization processes, because that obviously facilitates us as dentists to control these processes. And we are controlling them on a range of issues, as you can see here. We can control the carbohydrates as the motor of the biofilm imbalance. We can control the and demineralization balance using, for example, fluorides or other mineral deliverants. And we can, of course, also control the biofilm, which in itself is not so much the problem. It's rather the imbalance in the biofilm, the dysbiosis towards acidogenic and aciduric, so acid-producing and acid-tolerant bacteria. And of course, we are trying to control this on different levels, depending also on what kind of caries lesions we are facing. And that is the nice thing about the dentistry we are having these days. We are seeing lots of different options tailored to lots of different problems. And especially for caries, we've learned a number of things over the last 30 years. And one of the things is that caries is not really one disease. It's different kinds of stages of the same disease requiring different kind of treatments. And you can see here early lesions, non-cavitated ones, microcavitated ones, up to very deep cavitated ones. So really a progression stadium, which is more like a continuum, of course, on a histological level. And you can code that or classify it according, for example, using these ICDS stages or scores. What is very important, though, is that these different kind of stages or scores allow us at the end to control the lesions with different kind of efficacies and effectiveness. It's very easy in many instances to control the very early lesions because you can still clean it, you can still remineralize the surface to create a nice surface layer, whilst for the cavitated ones, that's of course much harder. And that at the end means that given this kind of complex nature of caries, we also have a number of different options. Of course, our traditional approach, restoring, excavating, invasive dentistry, that's still there. And as some of you might know, that topic of caries excavation is something which is very much at my heart. But nevertheless, on the other hand, we have a number of less invasive options, like, for example, those you know traditionally in, for example, restricting sugar intake, so sugar replacement dietary control. We can, as I mentioned, control the biofilm using oral hygiene, interdental brushes, flossing, but also antimicrobials or possibly in the future probiotics. So changing the microbiome activity and composition in the oral cavity. But also, and that is probably one of the main issues we're having there in carious control, fluorides and mineral deliverants like casein phospholipid, amorphous calcium phosphate, so CPP, ACP, or other calcium phosphate mineral deliverants. And these kind of strategies, they can be basically put as a second column in caries control. Invasive, restorative stuff, and the non-invasive, traditional preventive stuff. And the question is now, what do you do for what kind of lesion? And of course, if you have a patient like that one here, that patient has a number of issues. You can take a number of things away from that patient. The first thing I would take away is, please take bite wings very, very regularly. If you look at the clinical image, of course, lots of restorations, and of course, the second molar on the upper, the first molar on the upper left there, the restoration doesn't look pretty. But I personally would not think that we would have found all the early lesions without the bite wings. So the first thing is, if we want to treat carious lesions early on, we need to diagnose them early on. And that's why I strongly believe, and I know that other people see it very differently, I strongly believe we need more than only the visual tactile assessment to detect these lesions early on. And the second thing is, what are you now doing after managing all the deep lesions and all the major issues that patient has? What are you doing next to get control over these early carious lesions? So stages E2, which is a code for inner enamel half, or D1, which is a code for outer third of the dentin. So lesions just around the enamel dentin junction. Well, of course, traditionally, and that is unfortunately something when you look into survey data, and Nicola Innes from at that time Dundee and myself, we did it some years ago. When you look at survey data, a larger part of the dental community in the world would use restorations to treat these early lesions, because this is what we dentists do, we place restorations. But if we do this, we will also know that we will have failure of restorations. And of course, it's always easy to say it's not mine, I haven't done it. And that's also what I would tell you now for that restoration, because I haven't done it. But nevertheless, also my restorations, they do fail. And that is a problem because, of course, we need to retreat them. But it's also a problem because of every single small filling we're placing for an initial carious lesions in the long run being progressed using treatments at the end, and of course also restorations failing into larger fillings, inlays, crowns, and so on. Because no filling in the world lasts for eternity. At the end, we like to talk about permanent restorations, but no restoration is permanent, except maybe in an 80-year-old person, because of course the lifetime of that individual might be shorter than the lifetime of the restoration. But overall, we can say that the average lifetime of a filling is 8 years, 10 years, maybe 12 years. That's already quite good. But if we look into, for example, claims data, it's 8 years, 9 years, 10 years, not much more. And of course, that longevity of the restoration stretch of the spiral basically depends very much on how diligent we work. But nevertheless, that death spiral of restoration, which you see here, and that sounds a bit scary, and it's supposed to sound scary, that is something which is very much of the heart of us these days, not being as invasive any longer as we were in the past. And that is also reflected in a number of recommendations as to when intervene, for example. When and how to intervene. And the European Association of Cariology, ORCA, and the European Federation of Conservative Dentistry, these are just two examples, they have conducted a number of consensus processes and documents, and they are published by now internationally as well. And one of them focused on when to intervene, for example, also on proximal carious lesions. And what you can very much see here is that, for example, on the cavitated lesions, of course you will need, if they are certainly cavitated, of course you will need invasive interventions. But for the non-cavitated lesions, where you are sure they're not cavitated, and also for those ones where you are having a high chance that they're not cavitated, for example, if they're only in the enamel or just touching the dentin, for those ones, we at this point in this consensus document clearly rather recommended non-invasive or micro-invasive strategies and not recommended the invasive ones because of that death spiral of restorations. And that is, I think, something which most of us have grasped by now, that a minimal invasive but also a minimal interventional approach is probably something which might be beneficial for our patients. But the problem is that when we look at all these different kind of intervention options, we can push fluoride, we can push biofilm control, we can try to somehow, if you have a patient with hypersalivation, manage the salivary flow. We can try to intervene on the carbohydrate intakes on the diet. So we can focus on the basically determining factors for the pathogenesis of dental caries. But even if we do this, we might not be terribly successful. And I give you one example and then I will follow with the other ones. Fluorides, which is basically the cornerstone of caries prevention. If we are looking into the preventive fraction, that is only the prevention of caries lesions, that is something fluoride is quite good for. If we're looking at the pooled preventive fractions from a large number of studies which have been conducted, you can see that toothpaste prevents roughly 25% of caries lesions developing. A fluoride varnish prevents even more, maybe 50%. Gel and rinses are also around 25–30%. Which is not bad, that's really good. And fluoride is probably at the heart of the caries decline we are seeing in many countries since the end of the 70s. But what we also see on the other hand is it doesn't prevent all of the caries lesions developing. Fluoride doesn't avoid caries, it just slows its progression, that's one thing it does. And of course it reduces the number of cavitated caries lesions we can detect, that's the other thing it does. But it doesn't prevent all caries lesions of developing. And that is prevention. And if we're looking into the data for fluoride arresting caries lesions, it is even less optimistic. Sodium fluoride, for example, there's not that much data that it can arrest a large number of lesions when they have progressed to a certain stage. And the few studies we're having, for example, to fluoride helping in arresting cavitated carious lesions, like for example, something we do with a non-restorative cavity control, they are not really supportive of that technology because it's very hard to do this. And of course, you could use silver diamond fluoride. We have some more studies on that, and the efficacy, especially for root caries, is not too bad. So there are some areas where the fluoride works. But overall, we have to say, well, fluoride, of course, has its limitations when it comes to arresting carious lesions. And if we're looking into the other two aspects I mentioned earlier, which is dietary control and also oral hygiene, then it doesn't get much better. It doesn't get much more assuring there. Especially the dietary control is something where you would, when it comes from the logic of the disease development, you would assume that you should be able to control caries very well if you try and control diet. And in theory, you are. Of course, if you don't eat any sugar, you probably wouldn't have any caries. But the issue is that if we try to change behavior, and that is essentially something what we're doing there, we are not really good with it. Not only we as dentists, of course, the studies we're having, and there are not too many, show that dentists attempting behavior change in their patients, getting them to eat less sugar, changing their frequency of the meals and so on, that dentists are not really good at that, which might be grounded in how we, at least here in Germany, for example, educate dentists. We are not really focusing on educating them as behavior change managers. That's something which we are not really doing. But on the other hand, if we are looking into ourselves, for example, checking what we do, at least in Germany, in Christmas Eve, you're having lots of ideas about behavior change in the next year. You say, I won't smoke any longer, I will go more to the gym and so on. How successful are we with that? If you're looking at yourself, not really that successful, because behavior change is very hard. And that's also why, for example, dietary control is likely to be very hard. And that is, at least my guess, why the efficacy of these dietary control interventions are very low. Other stuff, like for example, sugar replacement, that might be more successful because it's something which is more intervention. It's something which is more concrete. Patients can do this. They can try and say, okay, I'm eating xylitol chewing gum now. That's something which is more in the hands of us as doers, because we are dentists, we do stuff. And if we're looking at oral hygiene, it's similarly difficult to change behavior on the one hand, and on the other hand, to really be efficacious with that, especially for caries control. Flossing and also interdental brushing are, of course, things we do recommend. But if we're looking into the evidence, it's not really clear how successful we are in avoiding carious lesions, for example, using interdental hygiene. And that is something which you can also see, for example, when you look into the data. So the median progression time of carious lesions, and you can see here at the bottom, what I mean with the different stages here, the median progression time in a Swedish cohort study, that's already quite old. The study is from the 80s mainly, but they really tried a lot of things to arrest carious lesions and to prevent them in a non-invasive way. Different fluoride regimes, oral hygiene instructions, biofilm control, and also the dietary control. All these things were attempted there in that cohort study over a longer period of time. And as you can see here, nevertheless, carious lesions tended to progress, especially once they developed. Once they developed, it didn't take months or weeks in most cases, but it took some years, and many of these lesions, for example, starting in an E2 stage at the beginning of the observation, many of them did progress under that non-invasive regime into D1 lesions, for example, so dentin lesions. And the deeper these lesions are, the faster they progress. That is something we for sure know. And that is why for years, dentistry has sought for alternative interventions, standing somewhat between these minimal invasive and non-invasive ones, because the restorative minimal invasive stuff is obviously very much invasive and escalating into the death spiral, whilst the non-invasive things are largely characterized by only a limited arresting efficacy. They are quite useful for preventing carious lesions, but for arresting, they are not really too successful, one has to say. And one of the strategies which has been discussed in dentistry since the 60s is obviously sealing. At the beginning, starting as preventive fissure sealant, for example, but very swiftly, also already starting in the 70s, people thought, well, if we can prevent carious lesions, maybe we can arrest them as well. Of course, the thinking was rather different. It was, oh, I can prevent lesions, but what happens if I, for example, seal not by purpose, but by accident, what happens if I seal carious lesions? And people started to investigate that. And what you found in these studies, and that's very, very convincing too, is that putting something on top of a carious lesion, on a porous carious lesions like in that scheme here, helps to install a diffusion barrier. And that diffusion barrier at the end manages to keep the acids out. So you might nevertheless have biofilm growing on top of the resin composite or the glass ionomer you used as a efficacy sealant. But the acids are not able to enter the porous enamel any longer, and the minerals are not able to leave the porous enamel. So that kind of microinvasive approach where you etch or condition the surface with some acid, for example, and you lose some micrometers and then you place a efficacy sealant, that approach seems very, very valid to, for example, arrest carious lesions. And then in the 90s, people said, well, if it works with fishes, why don't we also just try it on, for example, proximal carious lesions? And of course, the proximal carious sealing is something which has been tested in a number of studies as well and found efficacious, but it's difficult and it comes with a risk because you're not sealing a fissure, which is quite retentive, but a smooth surface, it comes with the risk of losing that sealant, of retention loss. And that is why in the 2000s, basically here at the Charité Hospital, together in the 2005 years, together with DMG in Hamburg, why the carious infiltration was developed. The idea is essentially exactly the same, the installation of a diffusion barrier. You put some lowly filled resins on top of the porous enamel. The enamel sucks that lowly filled resin in there due to capillary forces. You afterwards remove any kind of remnants on the surface, you light curious, and at the end you have exactly the same thing. You have a diffusion barrier, which now is not on top of the tooth, but within the tooth. But it's exactly the same idea. Acids can't go in, minerals can't go out. The only thing what is different is, of course, the location and where the diffusion barrier is installed. And because, as I said, that kind of intervention is somewhat more invasive than non-invasive stuff, but less invasive than the minimal invasive strategies, it was termed, and that is a term which was now also taken up in these consensus documents, it was termed microinvasive, because you're losing some micrometers during that etching and conditioning step, which you have, for example, when you seal, but you're not as invasive as a filling. Of course, the spectrum is at some point a continuum. Of course, in many invasive interventions where you don't do lots of prep any longer, when you use composites and you use only a minimal excavation approach, then you don't do much more than conditioning and sealing in some cases. But for a classification purpose, I think it's quite useful to say non-invasive, microinvasive, and minimal invasive. And of course, this is something which is very easy, and we are doing this on a daily basis, at least in our hospital, sealing these early carious lesions. And by doing that, you also prevent carious lesions and the sound fissures there. That is something which is technically easy, which is well established, and which is done by millions of dentists each day. As I said, the resin infiltration has a slightly different idea. You have, in this case, the sugar, in case of our tooth, the porous enamel with the porosities, sucking in their fluids. Then you light curious and you basically protect, using the resin, you protect the crystals, in this case of the sugar, in case of our enamel, the crystals of the enamel, from any kind of solvent. In this case here, it's water. Of course, in the case of enamel, it's rather acids. And as you can see here, that protected sugar cube, it's not dissolved. It's protected because the water can't get in there. The minerals, so the sugar crystals, can't get out there because you installed a diffusion barrier. And of course, one other thing which is something I would briefly mention before I show the infiltration technique very briefly, because I don't want to go into too much detail here. Of course, one of the things which we know from the resin infiltration is that you have a second advantage because you have that applicator kit. It's very, very hard technically to seal an proximal surface with an initial carious lesion in a closed dental arch. That's technically very, very difficult. I know that people are doing this. I know that people from Geneva are having concepts there, and I know that there have been conducted some studies also from all over the world trying to do that, where you protect the adjacent tooth with Teflon, and then you try to etch only the tooth surface you want to treat, and then you use some kind of either a bonding agent or a efficacy sealant to place the stuff there, but it's not really easy to do this. And I think this is something where the infiltration technique has a second advantage that it can be applied using very nicely designed applicator tips. And I just want to showcase the technology to you so that you know what I'm talking about before I come to the evidence. What you will find in the kit there, and that might be useful for you to know because many of you are clinical dentists and they might want to use it in practice, is a number of things. First of all, you can see in the lid, there's a cooking recipe basically. So you can just read up, if you can't remember on Monday any longer next week what I said, you can read it up in the lid there. You will find a wedge. I will explain that in a second. The applicator tips, I come to that too, and a number of syringes containing etchant, a drying solution, which is basically ethanol, and the infiltrant, so the resin, which is in a light-proof syringe so that it doesn't cure prematurely. The specific thing about that kit for proximal surfaces is that you can apply the stuff very targeted only to the tooth you want to treat. You can see that these applicator tips, they are basically like a double pouch. So they're like a bag with a perforation only on one side. You see that small perforation, which is slightly U-shaped, so that when you place it into the interproximal space, it exactly sits directly under the contact point, exactly where the carious lesion is. And when you then push into the syringe or screw, depending on what kind of syringes you're using, any kind of fluid, like in this case, the acid, it only leaves that pouch in that small window. So you prevent the whole tooth of being conditioned, and that's more important, you prevent the neighboring tooth to be conditioned at all. So what you do is, in the first step, you put your diagnosis based on bite wings in there. And that is something which, as I said, is very, very important, that you have a proper diagnosis for the X-ray there. And the first thing you would see here on this tooth, the lower right second premolar, is an early carious lesion. Just up to the dentin, so probably around the EDJ there. And as we will see later on, that is a very, very nice indication for the carious infiltration. And as a second step, you now need to clean that lesion, which clinically is very hard to detect. You can do this with pumice. I also just use superfloss because you don't need to do much effort. All you want to do is to remove biofilm because it would otherwise block the infiltration procedure. And then you place moisture control. You can use rubber dam in the rather premolar area. You could try and use mini dam, which is a rubber dam alternative there. Depends on what you like, but at least try a very, very good moisture control. Because if you don't really get it very dry in the drying step later on, the enamel doesn't have any kind of capillary forces. It doesn't suck in the infiltrant. And if it doesn't suck in the infiltrant, the whole technology wouldn't work because you wouldn't install your diffusion barrier. Then you separate the teeth. And if you find in that kit this wedge, you can now use it. You can, of course, also use a wooden wedge. This step is crucial. It seems so silly and so simple, but it's a crucial step. If you told your patient, I will perform a carious infiltration on you, it won't hurt, then that's the point where you notice that you lie to your patient. It will hurt, at least if you don't have anesthesia placed there, which is usually not required. Because you need, in a closed dental arch, to put the wedge there with some force. You need to thoroughly separate the teeth so that in the second step, you can now get your etchant material and the applicator in there. And the applicator, the double pouch, has a certain thickness. And if you didn't separate sufficiently, you will try to get it in, it will get wrinkled. And you will do this 2 or 3 times, and then you will throw the kit into the corner and you will say, that's a shitty product, to say it very clearly. So it's not a good product, and I would just do a normal restorative treatment now. So it's very important to separate these teeth, because otherwise all the subsequent steps are not really working well and you are very disappointed and of course also annoyed with the product. Then you place, as I said, that applicator tip there. You place it with this window, with the perforation, heading towards the surface of the tooth you want to treat. In this case, it was the lower right 5, so the lower right second premolar, the mesial surface. So the green stuff needs to head to that tooth, as you can see here. And then you apply the etchant. The etchant is a hydrochloric acid, so it's not phosphoric acid. And you etch longer. You don't etch 30 seconds, but 2 minutes. The idea here is not, compared to what you usually do with acid, it's not to roughen up the surface. The idea is to remove the outer layers of the enamel lesion, because we know that an enamel lesion is usually characterized by a surface layer, which, because it's permanently in contact with saliva and even possibly fluoride, is quite thick and well mineralized and helps to arrest a lesion. And you have the lesion body, which is very hypomineralized. And what we found, or what the inventors of the technology found in the late 2000s, is that you need to remove that surface layer, 10, 20, 30 microns thick, to open up the lesion body for the infiltration. So you etch for 2 minutes. As you can see here now, the acid is just exiting on the premolar, on the second premolar surface. Afterwards, you remove that, you rinse it off very carefully, and then you need to dry it. And to support that drying process, to really get all the water out, you use the I can dry technology, which is mainly ethanol. And if you have ever tried to clean your window, for example, using ethanol or acetone, you will see that it's really, really evaporating very quickly. And that's exactly what it does here. It helps to evaporate the water. After applying that, you use your 3-in-1 tip there, or syringe, to dry it. Make sure that it really only transports air and not oil. And then you place the infiltrant tip. And you infiltrate for 3 minutes. Make sure that whilst you're doing this, you remove all your lamps, so the operating lamp and also your headlamp if you use that, because otherwise the stuff will cure prematurely in the applicator tip. And in these 3 minutes now, the capillary force are basically sucking in the resins into the enamel. Afterwards, you remove it, you clean off any kind of remnants and overly placed material. You can do this with superfluous, for example. And then you lighter it from all 3 surfaces of the tooth, for example, using normal unit light or separate lights there for minimum 20, depending on your unit light, probably even 40 seconds from each surface to really ensure a good curing. And as you have all learned, these resins, as I said, they are lowly or unfilled, nearly unfilled resins, so they're thereby very lowly viscous, very fluidic. But because they are not filled, they shrink during polymerization. And the shrinkage leads to small porosities and so on, and these porosities need to be filled up, and that's something you do in the second infiltration step. So you repeat infiltration once more for a minute afterwards, you clean again, you lighter it, and then at the final step, you check your results, and that's one of the main issues with the infiltration. It looks exactly as before. It hasn't changed its appearance, neither clinically nor radiographically. So you need to educate your patient that you've now hopefully managed that lesion, but that it doesn't look different, and that if he ever changes the dentist, he should tell that dentist. And to support that, there's a small icon pass. So it's like a hard pass for poor people, basically. A small icon pass in the package which DMG provides. You can fill it in. You can put there on the 15th of September, I placed icon on this tooth. It was an E2 lesion at that point. And then the patient could, in theory, transport that when he changes the dentist to the next dentist. In reality, at least my patients are always losing it, mainly because it's not the hard pass, but only the infiltration pass. But nevertheless, it's available, and it might help for some patients at least. Now you might ask, how successful is that technology? Is it something which really works? Or is it experimental? Well, when we started out with gathering the evidence in 2015, in that Cochrane review here, we asked the same question. And we, of course, as you know from the Cochrane collaboration, which is very, very stringent and robust in their methodology of identifying studies and analyzing and synthesizing them, we only included randomized controlled trials. And then, as you know, it all goes through a sieve. You identify lots of studies, you break it down into those studies you find relevant, then you read all of them, and then you kick out even more studies because they're not applicable. So at that point, we ended up with 8 studies, which is not too bad. It's not great, but it's not too bad. 4 of them assessed sealing using resins versus non-invasive strategies, mainly composed out of flossing advice and normal fluoride regime and dietary control, so all the stuff I explained earlier. 3 of them at that point, infiltration versus non-invasive, and 1 study assessed a polyurethane foil versus non-invasive. There was 1 study which compared GIC versus non-invasive, and those of you who can count to 10 will now say, well, what is he telling? These are 9 studies, and he says it's 8 they identified. 1 of the studies had 3 arms, so they compared 3 things against each other. That's why we have 9 comparisons in these 8 studies. We updated that review in 2017, and I want to talk about more the update because the results are a bit more relevant for you because it's the latest results there. And at that point, so it's already 3 years ago now, we found 13 studies, so quite many more studies. And that development has been continuing until now. So if we would repeat that now, we'll probably find rather in the near 20 studies to that question. And we checked the risk of bias of the included studies on sealing and infiltration. As you can see here, red is usually high risk of bias, yellow is unclear, mainly related to poor reporting, where we just couldn't find out what they really did there, things weren't clear, and green is everything's fine there. In the different domains, you can see that these randomized controlled trials, they are assessed for stuff like, was it really a randomized trial? How did they blind the participants and staff? How did they blind the examiner who assessed the things afterwards, and so on. And you can see the biggest issues were usually in one domain, which is blinding of the staff and the participants. And that is something which is just not very easy. How do you blind someone who's performing a sealant on a proximal surface? That's very hard because hopefully that guy or that girl knows what he's doing. And it's very similar for the infiltration. Of course, and DMG tried this, you can see here the yellow ones, they sometimes try to support the trialist in supplying, for example, mock kits. So kits where you would think that this is now an active acid or an active resin, and you would place it, and then in fact it was just a sham. But that is also not that easy because, for example, the resin, if it's just apple juice, you would see it afterwards. If you would cure it and it would stay fluid, you would notice. So it's not really clear if you can at all achieve any kind of blinding. And that is just something we need to accept. And from my point of view, and that is also something I explained in that talk with which Marcelo mentioned earlier there in the Brazilian IRDR section, if we can't blind the operator, then we have to live with it. We have to try and blind the examiner. That's something which is very, very important and also very feasible here. But we can't change it. And that doesn't make these trials poor trials. It just means that in this formal assessment, they get a high risk of bias in that domain, but nevertheless, we can come up to good evidence there. And if you look at the network of interventions, you can see that many studies, of course, had the non-invasive control there with 670 teeth and individuals, 400 something in the infiltration, and 250 roughly in the sealing group. And if we then pool all that data, and that is something which we did using a so-called meta-analysis, a technology many of you might know, where you at the end weigh the evidence according to mainly the sample size, so how large was that trial, and then you pool it mathematically and you come up with an estimator, which you can see there is the diamond. Then you can see that, for example, sealing versus infiltration had an odds of 0.3. What does it mean? Well, it means that the odds of a lesion progressing in the sealant group versus the non-invasive group is roughly 0.3. So around about 70% reduction in risk. That's a lot. That's a lot. If you invent a pill which reduces the risk of mortality from, let's say, heart infarct by 70%, then you will probably be a very rich person by now. And if you look into the odds ratio for the infiltration versus non-invasive, it's even more convincing. It's 0.2, so it's nearly an 80% odds reduction. And if we're looking into the comparison infiltration versus sealing, as I said, there was only one study, a study from Colombia, which compared that in a 3-arm design. Then they found not a significant difference, but a trend. They showed that, oh yeah, it seems like infiltration is a bit better than sealing. And that is also reflected at the end, all these findings in the grading. And I don't want to go into that table here for too long because it's not that interesting, but what I want your attention to is the quality of evidence, the last column there. We have, and that is quite surprising, we have at the end, at least in our opinion there, moderate evidence. That's the second best grade. Moderate evidence supporting sealing and even high evidence supporting infiltration. And of course, that is something you can debate because for the infiltration, most of the studies were supported by DMG, which obviously leads to a very nice and uniform body of evidence. But on the other hand, you could say that, of course, some independent studies would also be nice. But if we're looking into the data as it is right now, and we updated at least the search last year, we have for the infiltration quite diverse data from lots of different groups, from lots of different countries, in different dentitions and risk groups. So at least what we can say there, yes, many studies were at least not always financially, but intellectually supported by the manufacturer. But nevertheless, the body of evidence is so heterogeneous. So many different groups basically came to very, very similar conclusions when it comes also to the numeric findings. If we go back here to this plot, you can see that all the studies pointed in the same direction. The studies were also similar with regards to the estimates, something between 0.1, the odds ratio, and 0.5. So there wasn't a study which said, oh, it's very, very close, and we don't know that. They were all very similar. So overall, I would say we have quite convincing data. So what we came at that point, what conclusions did we find? We said, well, non and microinvasive, they are both okay. And especially in low-risk individuals, older individuals, or enamel lesions, and I come to that in a second, one could even try only non-invasive fluoride flossing for now and see and monitor and maybe do the microinvasive only in case the lesion progresses. But especially for high-risk individuals, for younger patients, and for those where the lesion is deeper, it might be advisable to consider microinvasive, so sealing and infiltration early on. And of course, as I said earlier, we should consider restorative treatment only if there's a cavitation. So if, at least for the proximal lesions, the lesion is extended clearly into dentin, because even the D1 lesions, those just extending just into dentin, they don't have a very high chance, especially in our mainly low-risk populations these days, they don't have a high chance of being cavitated. And I brought you just a case example here, but for time reasons, I go about it a bit quicker. That's a patient of mine here. We tend in our university to code the different lesion depths and risks according to different colors here. And we conducted a number of treatments, invasive treatments, but also infiltration here, as you can see on this molar surface. And you can see the different steps here: etching, drying, flossing after the infiltration process, repeating the light, curing and infiltration, and afterwards. And that is something which I mentioned before. It looks exactly as before, and you shouldn't expect too much visual change. But that is something which we should generally not focus on too much. If you, for example, would be a physicist and you would provide someone with a heart pressure medication, you would also not expect anything to be seen immediately, and nevertheless you believe that something happens. That's why we do these studies at the end. Something which is very much at my heart, and I just want to mention it very briefly, is you need good diagnostics. You need good diagnostics, and what we know from a lot of studies, and also the new Cochrane review, which I had the pleasure to read in a draft some days ago, will, with a very high chance, come to these conclusions. Something dentists are not really good at is diagnosing early carious lesions. And I don't want to go into that nice image here of a study we just published in the Journal of Dentistry. I just want to lend your attention to the right part of the figure there. And we had different dentists assessing carious lesions on bite wings, D1 to D7, 7 different dentists. And you see the sensitivity, so the number of lesions they found. And you can see that the best dentist, D1, he had a sensitivity of around 60%. So he found 6 out of 10 lesions, which is not perfect, but okay. But look at the other dentist. Some of them didn't find anything mainly. And that is something which we also see in other studies. We conducted a systematic review and meta-analysis 5 years ago on the same question. The chance of not finding early carious lesions is 70–75%. We don't find 3 out of 4 enamel lesions on an X-ray if we are in a daily business there. And that is really a problem. And that's why in our working group, and I just wanted to show it for a second, because at some point in the next year, hopefully, people will be able to use these technologies. That's why in our group, but also other groups, we are designing or developing artificial intelligence solutions which can support us in doing this. And these solutions are much better in detecting especially early carious lesions than we as a dentist are. And that's just an example of how that solution looked into a pre-development stage there. It's now, as I said, soon available. It's called Dental X-ray, so you can look it up on the internet if you like to. But mainly what I want to say is that if you look into the column here of that graph again, which says model, that is the AI model, the artificial intelligence model. And you can see that this artificial intelligence model has the highest yellow bar there. So it detects initial carious lesions quite well. And funnily enough, it detects these initial carious lesions similarly well as the advanced ones, the red bar. The yellow and the red bar are mainly the same. If you look at the dentists, 6 out of 7 dentists were not too bad in detecting the advanced ones, the clearly dentin lesions. That's something we see because they are easier to see. But we were poor with the enamel ones. The model, the AI, doesn't care. And that's very interesting because it shows us exactly where the chances of these technologies are in detecting, especially early carious lesions, for example. I think that is a very, very valid use case, and it could help us in coming to better detection and diagnostic findings, and thereby enable better and early treatment of carious lesions as well. So that's the first thing you need to do. You need to diagnose properly, and only then you can ask yourself, what kind of treatment am I now using? And in these consensus processes, which I mentioned of EFCD and ORCA, we came to a number of ratings and evidence gradings. I don't want to go into any detail. You can read it up if you like to. But the consensus recommendations were very clear here. Of course, for non-cavitated lesions, that's the second consensus recommendation, non-invasive measures can be applied. This may be sufficient to arrest caries in low-risk individuals or early lesions. That's what I mentioned. And of course, the evidence base behind it is weak. As I said, there are not many studies, but it's common sense that you would try to do this, even if it's not the perfect treatment, because it's not very harmful, it's not very costly, and it's something which helps us in general to manage a patient's caries risk. But especially in high-risk individuals, or for lesions getting into dentin, there was a clear consensus, and you can see this there, the agreement of the experts was 83%, that microinvasive strategies should be considered. And it's based on a moderate level of evidence. That's what I mentioned when I provided you with the Cochrane review. And overall, and that is also something which is grounded in evidence, the decision between sealing and resin infiltration should be mainly guided by individual considerations. I personally think mainly by applicability, possibly also by costs, and of course your clinical experience. If you are the best proximal sealant person in the world, and this is something which you do, fine. But mainly for applicability reasons, I personally would probably prefer in a closed dental arch the infiltration. I, for example, nevertheless use proximal sealing, especially if I have access to it. So for example, if I work restoratively on the lower 5 distal, and I have a big cavity there, and I can access the 6 mesial, I consider sealing a possible lesion on the 6 mesial very often because it's easy, it takes me a minute, and then it's done. Of course, you could also use infiltration there, but then you need to ask yourself, why should I? It's much more expensive, it's much more effort. But in a closed dental arch, this technology, which you see here as an example, on the left side there, sealing is not easy to apply. And if we look into the evidence, we can clearly say that there's a higher chance that the infiltration will arrest the carious lesion than the sealing will do this. So as I said, I will try to be on time so that we have some time for discussion, 10, 15 minutes. I think I managed that somehow. So if I want to sum this up, what I would say there is that what we do with carious has changed quite a lot, mainly on our understanding, but also, of course, using new technologies and sealing, infiltration, and so on. These are rather newer technologies, at least to some degree. Initial lesions, they might well be managed causally. So you might try non-invasive stuff, or you could even say you should try non-invasive stuff. But in many cases, especially in high-risk patients, in younger individuals and in dentin lesions, you might not be successful with that. So in these cases, alternative and possibly also more reliable, you could use carious sealing, carious infiltration there. And both of them are evidence-based treatment strategies in my view. And as I said already at the beginning, you could regard them as first line and second line strategies. They are not contrary to each other. They are not each other's enemy somehow, but they are rather comprehensively belonging together in a nice and systematic treatment concept. And with that, I would like to thank you. And as I said, I have a brilliant view out of my office, as you can see here. No, it's not my office view, unfortunately, but my office view is nice as well. So whenever you want to visit us and look here out of our windows and see the nice dental clinic area in Berlin, feel free to come here. And I would be very happy to discuss with you now in the next minutes. Thank you.
Thank you very much, Professor Falk Schwendicke, for the brilliant lecture you have just given to us. And as you said, I think the best thing to do is to take advantage that we still have about 10 minutes to give voice to the audience and to the participants. And they have made a few questions here in the question and answer box. I don't know if you want me to read them for you, or can you read the questions
I
yourself?
can read it, yes. I just try and go, yeah, okay. Yeah, I can read it out. It's easier so I can mentally work with them as well.
Okay, please.
One colleague asked, resin infiltration is promising but not useful in low-income populations. What about SDF? Well, that is indeed a problem, and I fully agree with you. Resin infiltration is something which costs money, and it's more expensive than just applying fluoride varnish, and I understand that this could be a restriction in its applicability. As I said, I think SDF is quite promising, and especially for the two ends of life, for children and for the very elderly. We're having increasingly good data that it works, especially also for non-cavitated, but even for cavitated lesions. We see that there's efficacy. And if you don't have resin infiltration, I think SDF is one of the major strategies to arrest these carious lesions. However, and that is something you know when we work with it, it comes with this issue of staining. Of course, there are some technologies trying to alleviate this. Iodine formulations, for example, trying to revert that stain reaction there, or nano silver diamond fluoride. So I think we will see more of that in the future, and yes, it could be a good alternative. There's a second question there. Do you think the results of the systematic review are strong enough to recommend infiltration in a population-based strategy? I'm not 100% sure I understand what you mean with a population-based strategy, because of course, as an individual treatment, you would probably do this on each individual patient after indication. But nevertheless, I think they are, yes. As I said, we have now overall probably 10, 15 trials on infiltration from all over the world and on different kind of populations, low risk, high risk, younger children, adolescents, even adults. So also different kind of age groups there and dentitions. I think, yes, it's strong enough to recommend it. What else would we know? And what else would we need? What kind of evidence would we now ask for if we would say this is not sufficient? I wouldn't see that. These studies were all, as I said, conducted up to quite some good standards. I would like to see some more independent studies. That is the only caveat at this point. But overall, I think, yes, we can recommend it. And that is also what the Cochrane review did in 2015. It was a clear recommendation supporting these technologies. Then there's a question why some gels show less preventive fraction compared to rinses and paste. The gels, I don't want to go back now. If you remember the figure, the gels didn't have a significant lower preventive fraction or efficacy and caries prevention there than the rinse and the toothpaste. It was roughly the same. The only thing which stood out positively was the varnishes. And that is mainly due to dosage. It's due to dosage and due to the fact that they're sticky, that they're staying there for a bit longer. So the substantivity is just higher when you use varnishes. And that's why in many countries, at least to my knowledge, I think the US is a bit of an exemption there, but in many countries, we rather recommend varnishes than gels, for example, also in children, at least in Germany we do. Self-assembling peptides. That is one question here, self-assembling peptides, maybe just as an explanation because I didn't manage to mention that. It's a technology which is supposed to basically allow low molecular peptide fragments to diffuse into the carious lesion. And in that lesion, due to the acidic environment there, they reorganize into a peptide or protein scaffold and attract minerals. And thereby they facilitate mineralization. That's a very nice concept in theory. It's very attractive in my view. We don't have the data yet. There is one or two smaller case series cohort studies in vitro studies. There's one single randomized controlled trial from a university in northern Germany with a number of methodological limitations, which you always have in trials, especially because they needed to etch in one group, in the peptide group, they needed to etch the surface. And in the other group, in the control group, where they had normal fluoride varnish, they didn't etch. And they used, for example, laser fluorescence as one of the outcomes readings. And of course, etching will lead to laser fluorescence differences. So it might not even be the peptides which played the main role. It could well be that the etchant also had some importance there. So I think it's a good start, that study. It was published very highly in the Journal of Dental Research. But we need more data before we can strong-heartedly support that. What about sealing and infiltration in poor oral hygiene patients is one question. That is something which was only very briefly in my slide, something which is especially a case for these technologies, because our traditional non-invasive means like fluoride application, toothpaste, brushing, and so on, they largely rely on compliance, adherence of the patient. Sealing and infiltration do not. And that's why I think, especially in these high-risk, low-compliance patients, these technologies should be preferred. Of course, it would be nicer to change the patient's behavior, but as I said, that's not always easy. And it would probably not be a good approach to say, well, they didn't brush properly, so I don't give them the resin infiltration or the sealant. I think rather the opposite. That patient is especially suitable because sealant and infiltration, they don't at all rely on patient's adherence. Please also consider the questions from the VUA cell phone platform. I think that is something, Marcelo, you needed to do because I don't see the VUA thingy. I have it, I downloaded it, but I just have my computer here now with me. I will check the other questions in the meantime. Have you used Icon with success? But the lady says she had issues with the latex melting, the rubber dam melting. That is something I haven't heard about. So maybe if you have that issue, contact the manufacturer of the Icon kit and they might find out. I haven't heard that before, that it melted or disintegrated. Then, okay, there's one question. I don't believe resin infiltration will diminish caries burden. Well, that's an interesting question. No, it doesn't diminish the burden because, of course, it doesn't prevent any lesions from developing. It's only a treatment to arrest lesions. But as I said, the data is very convincing that it will arrest a large chance or a large number of lesions. Now many questions are coming in here. Is there not a chance that healthy tooth structure could be etched? Yes, there is a chance, and that can happen. And of course, that is something which is at the heart of the debate of my title. I said the good and the evil. And we have lots of discussion in other conferences that this etching is a bad procedure and you destroy healthy tooth substance. And yes, you do. You will lose, even in non-carious adjacent areas, maybe 0.5 millimeter next to the carious lesion, you will probably etch and you will lose some micrometers, maybe 10, 15 microns. That is unfortunate, and that is something which is not optimal. But if we look at the chance of being able to arrest these lesions with a 70% higher chance compared to fluoride or flossing, then I would probably accept that. It's a caveat, it's a limitation, but the difference in efficacy is just very, very convincing, and I think a good justification for that. So are there any more questions on the VUA platform?
Yes, there are a few ones, but I think we're not going to have too much time for these ones. I can pick one or two that are the most voted ones. One question is, wait a minute. Wow. Wait a minute. Okay. How is the insurance affecting the decision taken in Europe and in other parts of the world? Because in the US, it's hard to admit, but if you try remineralization and it doesn't work later, a different dentist or the insurance company can say, he didn't intervene? It is clear, wait a minute, it's clear a class 2 caries lesion. Maybe they just want to charge for a point to apply this or that, or to teach oral hygiene.
Well, that is obviously a debate we need to have. And of course, insurance systems, regulations, and these kind of things, they determine also what we do. But it's more a general question, I would say. So what we need to do as dentists, and I mean, everybody here attending IAPD is obviously a progressive forward-thinking dentist. We need to work to change these regulations and to change the legal situation. I don't think it makes any sense to drill into something just because you're on the safe side legally there. This is a bit like the diabetologist cutting off the foot early on so that the patient can't develop a diabetic foot. We wouldn't do that either. So I think it's our duty to provide the best treatment, to educate the patient, to record that properly. And then in many cases, hopefully also in the US, you are legally on the safe side. But I see that point there, yes.
Okay, and I think we still have a chance for one more question. This is going to be the last one. There are some people asking you about the silver diamine fluoride versus resin infiltration, and they say that they both have pros and cons on that, but they are asking you if there is any clinical decision-making tree to help them to make a decision.
Not to my knowledge, to be honest. And I'm also not aware of a lot of data comparing the SDF against the Caries infiltration, for example. There are some data in comparing it to other sealing techniques. So I think that would be interesting to look at. I don't think there is an established decision tree there. And I guess in many instances it will be nevertheless, especially considering these aesthetics aspects and so on, and the costs, which are not so much clinical and easily molded into a decision tree, it will be rather an individual decision.
All right, thank you. There are so many other questions in the WOVA platform, but I think we don't have too much time left.
I'm sorry, I tried to accommodate time for questions and even that didn't suffice.
No, but you did brilliant. You left 10 minutes, more than 10 minutes for us to interact with you. So that's very nice of you. And before I say thank you once again, I would like to tell everyone that we are very lucky because we invited Professor Falk Schwendicke to be with us for the second Global Summit meeting, IAPD, that was supposed to be in Taiwan in November this year, but due to the coronavirus, we had to make a decision to postpone this meeting to the beginning of February. It's going to be February 2022, but I'm sure Professor Falk is going to be with us again in this meeting. And of course, we're going to have a chance to see you next year for the IAPD Congress in the Netherlands. So we still have many other opportunities to be with you. So final words, final remarks, if you want to say something.
Final words. Thanks for having me. Thanks for having me. It was an honor.
Be sure that it was a great honor for all of us from IAPD as well to have you with us today. Thank you so much. See you soon. Have a good day, everybody all over the world. Thank you.